We then give the child something to eat and drink, and you can see this is just a representation really of what we might do as an assessment. So, for example, this child is having some milk from a bottle, and we'll watch very carefully to see how they manage with the oral phase that I talked about earlier, so chewing, moving through the mouth. You'll also see us listening with a stethoscope, and with an older child you might see us also feeling for laryngeal elevation. And there we're looking at the sounds we're listening to the sounds of the swallow and any signs of difficulty, so coughing, any changes in breathing. When you've listened to quite a few swallows, you know what it should sound like, and if it sounds a little bit different, then that can be an indication that they might be having some difficulty. And then from all that assessment, we may be able to make some recommendations or give some advice. Sometimes we decide that we need a more objective assessment, and you may have heard talk of a video fluoroscopy, which is a more objective assessment of swallowing, which allows us to see when and why aspiration is happening, and to try different consistencies and positions and techniques to see if that has any effect. This is just an image of a video taking place. It's not an invasive procedure at all. It's basically a moving X-ray. So you can see the baby here, and she's being fed probably by mum or a familiar adult. We would give the child whatever they normally have to eat or drink with a barium contrast in, so that it shows up on the X-ray, and you can see here, just in the background, the X-ray picture. And that's a moving picture that we'll be watching together with the radiologist, who's the doctor in the room. And then we can also, it's recorded, so we can watch it back later, make feedback and recommendations. And it can also act as a comparison. For example, if the child comes back in a year's time, we can see what changes have occurred. I'm just going to give you a basic idea. I don't know if you can see that. Can you see that? Of what we see on a video fluoroscopy. This is a normal video fluoroscopy, so it's just to give you a bit of an idea, really, of what we can see. Just to orientate you, here is the back of the head here and the spine. The lower jaw, this bit of air here is where the mouth is open, and you can see quite clearly the airway here, which is the kind of white. And what you're going to see is the food, which will be black, going into the mouth, and then just watch to see how quickly the swallow happens and how important it is to be able to coordinate your breathing with that. Okay. Oh, it seems to be playing on the computer and not on the screen, unfortunately. Okay, is that?
Sorry.
It's playing on the computer but not on the screen.
Yeah.
Do you want me just to carry on?
Colour, haven't we?
Yeah. Not to worry. You can get the idea sort of from the picture.
It's gone black and white, isn't it?
Oh.
It's blue.
Still not going to play. Okay. Well.
Double clicking.
Well, it's playing on here though. Okay. Well, what you would have seen was just how quickly and how well coordinated the swallow is, and you can see you would be able to see from that actually if something little goes wrong, it can mean that some of that material is then entering the airway. Okay, so what can we do to help? The things I'm going to mention here are just kind of general areas that we tend to look at. Obviously, the recommendations that we make are based on the detailed assessment of every child, and they're individual to each child, but this just gives you an idea of some of the areas that we look at. We may look at positioning, because when a child is eating and drinking, it's really important that they have adequate breath support to be able to coordinate their breathing and swallowing. That they're seated in a good position, so they're not having reflux, for example, and also that they're just well supported and balanced, so that their effort can go into eating and drinking rather than in trying to maintain their balance. And this is just an example of a kind of supportive chair that we might use. We might make suggestions in terms of changing the consistencies of what we eat and drink, or what the child eats and drinks, sorry. So, for example, if they have oromotor difficulties moving the food around their mouth or chewing. It may be that they manage much better with a softer consistency rather than something with hard, chewy lumps in. Some children manage better with thickened drinks, so by putting a powder in that makes a drink much thicker, more like a milkshake, because that moves slower through the mouth, so they have a better control over the liquid, both in the oral phase and in the pharyngeal phase, and also gives them a little bit more time to close their airway effectively before the liquid passes into the esophagus. We might suggest things like different teats, special cups, for example, particularly if a child is having difficulty actually getting the food or drink into their mouth because they have poor lip control, for example. Sometimes different teats or cups are useful. And then together with the medical team and the dietitians, we talk a lot about managing nutrition, because I talked earlier about how important it is that the children keep their nutritional requirements up. So someone asked in one of the sessions earlier about supplementation, for example, different calorie supplementation drinks, and that's something that the dietitians will always look at. Some children do need alternative or supplementary tube feeding, either in the short term or in the long term. For example, we've recently had a baby who had a respiratory crisis, really, and at that point, because of that importance of the coordination for feeding, wasn't able to feed effectively and was fed with an NG tube, and then and now is feeding orally. For some children, over the longer term, they do need continued supplementary feeding, or if, for example, they are at high risk of aspiration on many consistencies, then it may be that they need a gastrostomy in the longer term, which is basically a tube that goes straight into the stomach and can be fed with a liquid feed through there. And for some children, this works well combined with oral feeding, so they're able maybe to have favourite foods through their mouth, so eat and drink favourite foods, maybe still take part in the social kind of activity of eating and drinking with their family, but meet most of their needs through the gastrostomy, which then also takes the pressure off having to eat and drink certain amounts of certain things. So our experience of Pompey, a couple of people said obviously it's quite a small population, and unfortunately the research base is really very limited. We've had 3 children in the last 3 months at Great Ormond Street, and even within those 3 children there is a huge variation in how they present. So some children don't have any difficulties feeding at all. Some children may have difficulties with sucking. They may have difficulties with their oromotor control, so moving their lips or their tongue, that strength may be reduced. They may fatigue over time, so for example when taking a bottle they might manage the first 10 mils really well coordinated, no problems, and then as they get tired towards the end of the bottle, find that much more difficult and perhaps present with a risk of aspiration. And there are some children who do present with quite a significant risk of aspiration and need supplementary feeding as a result of that. And I would say that one of the things that appears to link the few children that I've seen in my time at Great Ormond Street is the impact of the respiratory difficulties, because that's something that all the children seem to have in common, and that can impact in different ways on their feeding. So what next for speech therapy at Great Ormond Street? I've explained sort of how we work with the children at the moment. Obviously, this is a new post, and I'm new in post as well. So my aims really for the next sort of couple of years are to be able to offer a systematic service to assess and follow up the children who come to Great Ormond Street, and to have that important role in the multidisciplinary team, and really to try and increase our knowledge base of feeding and swallowing in Pompe disease, and to see both sort of what is the natural history of feeding and swallowing, what the impact, if any, is of enzyme replacement therapy, and what seems to work most effectively for the children who we see, and hopefully to start working sort of in collaboration with our colleagues around the country, and to increase that knowledge base and perhaps to devise sort of new systems for our assessment and follow-up.